There is no answer to avascular necrosis, Dr. Ramesh, and there is no gold standard as far as the management is concerned. I have seen cases of vascular fibrografting. Rakesh knows, Kara at Jaipur went from my institution for treatment and collapse occurred. So there is no gold standard. Work is going on. You may put in umbrella with a graft, or you may put in some implant with a surface kind of arthroplasty. Collapse will still occur. Yes, no research is done as far as osteotomy is concerned because industry is dominating for THR. But I tell you, if we talk of simple in terms of osteotomy, you are putting mesenchymal cells, you are putting growth factors, you are putting BMPs, everything. What is this osteotomy? Normally you have bone marrow aspirate, put at the site of non-union 3-4 sittings, 6-7 sittings to invite union. But here you are extending an invitation for the proliferation of mesenchymal cells, the natural stem cells, the natural osteoblasts, and a race may go on between the creeping substitution, again neovascularization. Are you able, or the process is able to remove that dead bone, the aseptic bone, and cause the viability of the head of the femur? I think this is the future, and the scientists, the researchers must look into it. Something will also come from Dr. my dear friend from Nagpur. He will talk to you regarding its management. Classification, a lot has been talked by Dr. Ramesh, particularly RC classification, the recent one, the latest one. Here we can do quantification in this Pennsylvania classification, where the involvement is 15% or 15 to 30% or more than 30%. That is mild, moderate, or severe involvement of the head of the femur. And these are some of the various procedures, the operative options for the management of this entity, which has been very highly spoken by my friend Dr. Ramesh. 2 types of osteotomy, 3 types of osteotomies we are doing on: valgus, varus, and trans-trochanteric rotational osteotomies of Sugioka, which he has shown some pictures. It has a mechanical role and a biological role which has to be investigated seriously with a concern. That's all we want to find the management of avascular necrosis. The cause may be any. And as usual in literature, you find that this brings about reduction in the intraosseous pressures and improvement in microcirculation, which again has to be looked in. And this enhances the repair activity and healing process by stimulating neovascularization and new bone formation. That is what osteotomy is supposed to do. And I will talk to you on my certain observations, because the real research is still not being done as far as this subject is concerned. Mechanically, one can take away the well-circumscribed area of necrosis away from the weight-bearing dome, and that may facilitate the neovascularization and bring about the viability of the avascular or aseptic zone of the head of the femur. You see here, if you see the relative classification, the head and neck is involved. And we have done a varus osteotomy. You see here, this is after 231 weeks. And this is after 20 years, the head is completely viable. Just a varus osteotomy contain the necrotic area, bring it away from the weight-bearing dome, which was there because of the valgus position. It works in 3 situations, both in pre-collapse, collapse, and in arthritic situations. You find here this is type 3 crescent as per Fickett and Arlett classification, or for other classifications here. And if you do an osteotomy, this takes away the head of the femur away from the weight-bearing dome, and the head becomes viable. You find here still the cystic changes are there, but there is no collapse. So in pre-collapse situation, osteotomy does very well. You have to decide you want to do a valgus osteotomy or a varus osteotomy. This is 237 weeks, and you find here this is after 11 years, the head is viable. There is no deterioration at all. And I have done the MRI on this patient that showed the enhancement changes. Again, you see the relative classification, valgus osteotomy done. You find here the joint space is slightly reduced. There is sclerosis, but the head is viable, and this is after 24 weeks. Excellent motion, excellent movements. This is when she was studying for a master's degree, and now she is married. This is the daughter, and at her age, I operated the mother child, and you find that there is good follow-up. The head is viable. Pre-collapse situation. Works very well even if there is a uniform collapse. Now see my follow-up. This is not a research. I'm just showing you my results. There is uniform collapse of the head of the femur. See, this is 6 years male. I did it in 1992. There's failed osteosynthesis. And you find there's increased density and there's loss of bone. This is 28 weeks. It is united. The capsule is not divided. Just valgus position. You see here, there is uniform collapse, reduced in size, united below along the calcar, not here, and this is just pre-operative. 14 years, 6 months back, and patient has excellent function. He can squat, he can sit cross-legged. So uniform collapse, even if it occurs after an osteotomy, this works very well. We have to look into it, why it is so. Again here, non-union here. After 10 years, there is, you find grade 3, 4 changes. Mild collapse here, increased density, implant is out, but this patient is still pain-free. So osteotomy works even if there is a collapse, or a uniform reduction in the size of the head of the femur. Same is here, you find at 98 weeks, it is viable. At 305 weeks, you find there is a collapse in the weight-bearing dome. This is 13 years, you see there is a collapse. Both in AP view as well as in frog leg view, but the patient has excellent range of motion. He can squat on toes and sit cross-legged position even after 15 months of the collapse in this patient. So short, why it is working, what is the reason, I don't know that. See here, there is protusiae, avascular necrosis and arthritis. Patient is still pain-free after 16 years, and this is after 21 years. The range of motion is decreased, abduction is decreased, flexion is decreased, but the patient is pain-free. So AVN with arthritis, if osteotomy is there, it still works. It's most valuable in treating patients with stage 1 and stage 2. This is what has been said and emphasized. This is what literature says. In pre-collapse stage, the core decompression. Now this is one of the cases of core decompression. He is a doctor. You find here where the drill was put in. This again, where the drill was put in, it works. It is stage 2, but stage 3, crescent, you see. If you put a fibular graft, this fails to maintain the structure. See here, there is a collapse. This is the fibula. This is after 300 weeks. The boy studies in St. Stephen's School, college. And here, if you do now a valgus osteotomy, it will work because there is impingement here. Abduction is limited in this patient. There is impingement, but there is full range of motion as far as flexion is concerned. So this is after 11 years, and I feel like doing a valgus osteotomy, which will positively work. Now see here, the fibular grafting is done. There is a crescent sign, but there is a collapse also. So there is impingement. This patient is referred to me from Kanpur, but I don't think now valgus osteotomy has a role because there is already a collapse. And a big area, more than 1/3 of the head of the femur is involved. This much area is the collapse. So answer is THRS is at this situation. However, here you find that there is a crescent sign. You can confirm the avian changes on CT because it's a treated case. Now here, I have put a fibrograft to give a support and done the valgus osteotomy with it so that the aseptic zone is away from the weight-bearing dome, and this has worked very well. This is after, you see, this is CT after this treatment. Here I put in the fibula. This is after 10 years, still working. Osteotomy with fibrograft in the area of crescent to prevent the collapse and take it away from the weight-bearing dome. This can be repeated if OA changes occur, the joint space is reduced, thinking that other healthy cartilage area will come in congruency to give him a good function. And here, this was the initial osteotomy, and this is the second osteotomy, though there is valgus, and patient had some limp because of the disturbance of the body lever arm and muscle lever arm, but the patient was pain-free till his death. And I say here that by doing osteotomy, you invite proliferation of your mesenchymal cells, the stem cell, the osteoblastic activity, and maybe this is the future when more and more research is there. This is what is published in Campbell's My Technique by Magu et al., and I thank you very much. Thank you.
Thank you, Dr. Magu. Any questions, please? Yes, sir.
How exactly do you plan your osteotomy? Like, do you do a CT in all cases with 3D reconstruction? Do you add flexion extensions to your valgus?
That will depend upon the area of the involved. If you want that the healthy area is located superiorly and posteriorly, you will do a flexion osteotomy, and this will come in the weight-bearing dome. So you have to plan it on the CT or on cephalad or caudal X-rays. And normally, if you excise a wedge of 20 to 30 degrees, this will bring the head of the femur or the aseptic zone, which is generally there is you find avascular changes. This will bring it out of the weight-bearing dome of the acetabulum. And you will feel that the abduction of this patient is increased because of the abduction osteotomy. And this gives a healing effect positively.
To bring the healthy head into the weight-bearing area, if you need to extremely valgize or varize, do these patients have a limp?
Yeah, you should not do extreme valgus.
Yeah.
Because the body lever arm will be disturbed.
So there is a limit.
The level of the top of the trochanter must be at the level of the center of the head of the femur. So you just excise a wedge of about 20 degrees.
It's maximum 20 degrees.
Yeah, 20 degrees.
And suppose by chance the avian progresses, does it make your arthroplasty options
Yes, you can still do
compromised?
that is what I want to say. You can still do a THR. You should not do too much of medialization or lateralization. But remodeling helps you, and I have seen that even after 14, 15 years, a good marrow is formed, a new marrow is formed, and THR is not difficult. A lot of literature is there.
Thank you, sir.
Like he said that in cases where the area is much more than limited to a area which can be sort of taken away from the weight bearing area by an osteotomy, because you can go only up to a certain extent in vulgarization. So is it possible that more than mechanical, it's the biological components that are acting in?
Absolutely. This is what Marty has also written.
Yeah.
See, even if the whole of the head is involved, but there is no collapse. Osteotomy works very well.
Possibly some decompression element is also happening with osteotomy.
Yes, this causes decompression because you are making a track and then taking it out. Pressure is released, the venous pressure is decreased at the osteotomy site, and neovascularization starts.
Neovascularization.
This is an area of research which we should take up now.
I think it's possibly more of biological factors than mechanical factors which are contributing in avian.
Both. More of as such mechanical associated help with.
Because
biology.
in a lot of these cases, the area of necrosis is not completely taken away from the weight bearing zone.
Yes, not weight, but still healthy cartilage is there with subchondral bone which gives support.
Thank you. Any other questions, please?
So any go ahead.
Which are not available now. Can we use DHS like things and?
Yes, you can do with DHS also, but be careful that there is not too much of medialization with With a double angle blade, you can cause lateralization and can give length. But with DHS, which is 135, you will cause more of medialization. So you should prevent medialization.
So any study related to the perfusion, change in the perfusion, before the osteotomy and after the osteotomy, how the perfusion changes?
That is what I want to tell you is an area of research. We have to
right.
look into that. We have to do this study in animals, basically dogs, and see the perfusion before and after that.
We can do in even in humans directly, because if we do a standard of care procedure like an angio to see the flow in
when
those particular.
implant matters, you have a titanium implant specially, and then you look into it. So we don't have that osteotomy implant still with not titanium. 120 is not with titanium.
Regarding, there are two things. One is a mechanical, one is a biological. If the biologic can be achieved by a simple core decompression, I don't think then we have to really go for osteotomy for that level. Regarding the mechanical, if you study the epidemiology of, I am talking non-traumatic AVN as such, 70% of the cases, whole of the superior part and medial part is involved.
Yeah.
Valgizing it will still bring, and for an osteotomy principle for AVN, it is said that 50% of the weight bearing dome should be intact to take care of the non-weight of the affected area which is not weight bearing.
Absolutely.
So till you are not able to bring 50% up, this is not likely to be helpful. And in that kind of a medial involvement, that much valgize is not possible. Second, when you talk about Suzioka, we understand in Suzioka we are rotating it backwards. Now the vascular supply is coming from anterior side. Now when you twist that area you are still stretching that area, and by rotating anteriorly, superior is involved, anterior is involved. If you want to bring the posterior part, you need at least 40 to 50 degree of rotation. Doing that much of rotation, I have done it. Doing that much of rotation is still not sufficient enough to bring that amount of area up to bear the weight. So probably, I don't know, there is a literature which has favored some of these osteotomies. I have always tried every case to look for whether I can do osteotomy, but I have not been able to find very many cases able to go for mechanically bringing it up. Biologically, surely it has definitely got an effect, and that is what we rely with the core decompression.
Yes, rightly, Dr. Ramesh. If more than 50% is involved, there's a role of trans-trochanteric rotational. And the limitation is, again, you said that there can be twisting of the whatever vascular vessels are left, they will be twisted. Certainly, again, the word comes that there is no answer to it. A lot of research is required. But osteotomy is both mechanical as well as biological. If it is a gone case, you try any method, THR has to be done.
I think Negro also played some role in many of these cases, because a lot of them are bad radiologically, but still they are very good functionally or clinically.
Yeah.
So they may not be sometimes correlation between radiological picture and a clinical picture.
So one question, sir.
Thank you.
Sir, one question, sir. So biology of idiopathic AVN is different, and biology of post-traumatic AVN is quite different.
And of alcohol is different, of steroids.
In your studies, have you compared between the efficacy of osteotomy between the idiopathic AVN type as well as the post-traumatic? Any results or anything?
I have not done, sir.
Okay, sir.
These are my observations.
That is what
tried in the
exactly
beginning.
we try to compare between traumatic and atraumatic. Incidentally, because traumatic is always clubbed with non-traumatic. In all literature around the world, there are 100 cases of non-traumatic and 15 cases, 10 cases of traumatic. We try to have a literature analysis that we could separate out all the traumatic cases. We could not. We had our own 17 trauma cases where we did core decompression, which is all other cases of this thing, non-traumatic type. What we observed while we were successful in a very early stage, I am saying 5 months, 6 months of the onset, while we were successful in 70 to 80% cases with simple core decompression, here our success rate was not more than trauma, and I am not talking about fracture neck femur, because the AVN occurring after fracture neck femur has got a different outcomes. This AVN coming after dislocated hip is a different outcome. So I am only talking about dislocated where the fracture has got no implication on my results. So the outcome of a traumatic AVN is 50% only, maybe because the pathology is different. There was an ischemia which was coming up due to the edema. You decompress it, edema comes. Here we don't have that edema. It is coming subsequently after the dislocation ischemia. And once whether the core decompression will actually benefit ischemia, this is doubtful about it.
Thank you, Dr. Sen, and thank you, Dr. Magu, for a very good talk on osteotomies, giving the other perspective to the AVN management.